Everybody, thanks Dr. Alaa for the nice presentation. First of all, I would like to thank Dr. Mahmoud Salah and congratulate myself and him for the success of the conference. Also to thank Dr. Ahmed Sakr and thank all of you for being part of this great team. Secondly, we just take a little bit break from the arterial interventions and talk about the targeted ablation in CVI, focusing on the small saphenous vein and perforators. As all we know, that I have nothing to disclose. Identifying the underlying causes of reflux in CVI patients is a little bit significant and challenging, and the small saphenous vein and perforators can be a rule in the persistence of CVI symptoms even after the ablation of the great saphenous vein. And I asked the floor, how many patients came to you by pain and resistant pain and swelling after doing the great saphenous ablation? But many surgeons refrain from solving this issue due to the difficult access for the small saphenous vein and the need to change the patient position from supine to prone, and high incidence of complications in the literature, the nerve injuries and DVT. As all we know that the SEEP anatomic classification, the perforators and the small saphenous vein is part from it. And the anatomy of the small saphenous vein, it begins at the posterior to the medial to the lateral malleolus and ascend in the leg, accompanying the sural nerve until it reaches the popliteal fossa and merge with the popliteal vein at the level of the crease of the knee. But there is a 5 type of small saphenous vein termination that encountered by Francois and Glou. 2 of them, there is a saphenous-popliteal junction, and 3 of them, there is absent saphenous-popliteal junction. So our work in Mansoura University, and by the way, I'd like to thank our mentor, Professor Ehab Saad, for his supervision on this data. We published a paper on the radiofrequency ablation of the incompetent small saphenous vein. We ablated 52 limbs in 34 patients. Our aim was the technical success rate. It's the total occlusion of the vein with absence of reflux and reduction of venous clinical severity score and Aberdeen varicose vein questionnaire at 1 month, and follow up at the incidence of complication and recurrence up to 1 year. Our technique was using the axis of the small saphenous vein from the supine position, just doing a lateral rotation for the knee. And using the duplex guidance, we do the insertion for the sheath, as it's shown in the picture, and advancement of the catheter up to reach 2 centimeters before the saphenous-popliteal junction. And one of the crucial points is the intumescent injection. By increasing the fluid around the small saphenous vein and separating the small saphenous vein from the sural nerve, you must inject the fluid all around the vein. It's not from the upper part or the lower part, it's all around, just to separate the sural nerve from the small saphenous vein. This is the demographics, and this is the results. The technical success was in all patients. Okay, we did ablation for the small saphenous vein, and the venous clinical severity score decreased significantly at 1 month. Also, the AVVQ was improved also. And on follow-up, 79% of the patients continue the follow-up, and we found that all of them, there is no recurrence. But we found that there is an incidence of paresthesia, maybe from the sural nerve. It was in 3 patients, okay, and they are resolved on follow-up. the resolution of the paresthesia from 2 weeks up to 6 months. But when we found the literature or reviewed the literature, we found that the sural nerve injury with the surgical intervention is more than the radiofrequency ablation. It was 20%, reached up to 20% of the cases, but still higher than the endovenous laser ablation. It was 2%. Another published randomized controlled trial, it was held in Mansoura University, and I was part from it. It's done on 190 patients with a postphlebitic resistant ulcer. Resistant ulcer, despite of doing great saphenous vein ablation or stripping, there is still reflux along the perforators around the ulcer. So we recruited the patients into 2 groups, compared the radiofrequency ablation versus the compression alone. We used here the radiofrequency catheter, and we punctured the perforators after proper positioning of the probe, just to make a longitudinal cut section and do a puncture to the perforators. And like in this video, until we reach the perforators and ensure by the duplex the proper positioning. The importance of proper positioning is to avoid advancement the catheter to the deep veins, so we can hurt either the deep veins or the arteries. Okay. After that, we do intumescent injection, okay, just to avoid the injury of the surrounding structures, and start ablating the radiofrequency catheter. Here we advanced the catheter and then withdraw it to ensure that we are far away from the deep veins, and doing the ablation for the procedure. And this is the follow-up data. The occlusion rate for the ulcers in the group A, we found that it reached 90%, while in group B was 77%, and there is a significant difference between both groups. Also, the recurrence in group A was 12%, and in group B was 33%. And when we go back to the literature, we found that a systematic review and meta-analysis found that compared to compression alone, radiofrequency was the only treatment displaying the statistically significant impact on ulcer healing, while the endovenous laser ablation was significantly lower in the recurrence rate. And this was in accordance with our work. So my conclusion is thermal ablation could be considered in treatment of CVI patients with small saphenous vein or perforator incompetency. Proper duplex assessment, either pre or intraoperatively, to delineate the course, termination of short saphenous, and perforator location. This ensures a high success rate and lower incidence of complications. Okay, thank you.